Hello everyone, I'm Anas Al Ubaidi, and the topic for this session or this lecture is final assessment about cardiology and pulmonology scribe certification exam within chapter 28 of review of cardiology and pulmonology scribing within the Certified Medical Administrative Assistant course program by ACMSO. Introduction. The final assessment cardiology and pulmonology scribe certification exam represents the culmination of rigorous training and preparation for advanced medical scribes aiming to excel in these two critical specialties. This certification validates a scribe's proficiency in recognizing and documenting complex cardiac and pulmonary pathologies, interpreting nuanced diagnostic data, and contributing to seamless multidisciplinary care. For students in an advanced medical scribe course, passing this assessment is not just a professional milestone, but also a gateway to rewarding career opportunities in specialized clinical settings. Cardiology and pulmonology are among the most demanding fields in medicine, as they often involve life threatening conditions and intricate patient histories, from chronic heart failure and arrhythmias to obstructive lung diseases and interstitial lung disorders. The range of cases encountered requires meticulous attention to detail. The certification exam assesses core competencies such as symptom documentation, diagnostic interpretation, and use of standardized templates designed to capture the complete clinical picture. As for example, for instance, documenting chest pain with precision considering onset, quality, and triggering/exacerbating factors enables clinicians to distinguish between injury and other conditions with while pulmonary function test PFT interpretations guide decisions on treatments like bronchodilators or oxygen therapy. Beyond symptom recording and diagnostics, the exam emphasizes the ability to handle complex cases, including cardiopulmonary overlap syndromes and acute emergencies like pulmonary embolisms or myocardial infarctions (MI). Candidates must demonstrate their understanding of how these conditions manifest, overlap, and interact, ensuring they capture critical information that supports timely interventions. This proficiency extends to scenarios requiring collaborative care, for instance, cardiologists, pulmonologists, primary care providers, and other specialists may be involved in managing the same patient. Scribes are responsible for ensuring facilities, their documentation facilities, this, their documentation facilitates this collaboration, providing clarity on results, recommendations, and treatment plans. Certification in cardiology and pulmonology documentation also underscores the importance of compliance and professionalism, adhering to HIPAA regulations, as in HIPAA in USA, and maintaining accuracy in ICD-10 and CPT coding are integral components of the certification process. Such skills safeguard patient confidentiality, minimize medical legal risks, and streamline clinical workflows. For example, accurately coding conditions like atrial fibrillation ICD-10 I or 148.91 or documenting complex procedures such as pulmonary biopsy CPT 32405 is essential both for effective care and proper billing reimbursement. Passing the certification exam provides numerous professional benefits. It distinguishes scribes as experts in cardiopulmonary documentation, making them valuable assets in fast paced, high pressure hospital departments or specialized private practices. Furthermore, the certification enhances career credibility, showcasing advanced knowledge and skills that exceed general scribing standards. Whether the ultimate goal is working alongside cardiologists during catheterizations or assisting pulmonologists in cases of non-invasive ventilation management, this certification opens doors to specialized roles with greater responsibility and enhanced career satisfaction. Key points. Mastering symptom documentation. Symptom documentation in cardiology and pulmonology is a primary exam focus. Candidates must demonstrate an ability to record signs and symptoms with accuracy, detail, and relevance to diagnosis. Recording chest pain characteristics, key details include onset, location, quality, duration, radiation, and triggers or alleviating factors. Example, patient reports retrosternal chest pain lasting 20 minutes, described as pressure radiating to the left jaw worsened by physical activity with no relief from antacids. Why it matters enables differentiation between angina, MI, myocardial infarction, and non-cardiac causes like GERD, gastroesophageal reflux disease, facilitating timely interventions. Documenting dyspnea or shortness of breath. Focus here specify if associated with exertion, positional changes, for example, orthopnea, or acute onset include severity and duration. Example, patient complains of progressive shortness of breath over 3 weeks, aggravating upon lying flat, requiring two pillows for comfort at bedtime. Relevance here supports differential diagnoses such as heart failure, asthma, COPD, or interstitial lung disease. And here is a diagram summarizing the comprehensive chest pain documentation. Tracking palpitations and syncope. Details to capture: onset, triggers, circumstances, exercise slash rest, and associated symptoms like dizziness or fainting. Example, reports intermittent palpitations over the last month, worse at night, recently accompanied by brief episodes of dizziness. Significance indicates the need for investigations like ECG or EKG or Holter monitoring to detect arrhythmias. Monitoring cough and sputum. Key points include duration, quality, dry or productive, and color or presence of blood in sputum, not any associated fever or weight loss. Example, chronic dry cough for 2 months, no sputum, associated with mild wheezing, no fever or systemic symptoms. Clinical use distinguishes asthma, bronchitis, or malignancies from cardiac cough related to CHF, congestive heart failure. Edema and weight changes. Details needed: record time of onset, specific locations, for example, lower extremities, and diuretic response. Example, reports bilateral lower limb swelling persisting for 2 weeks, worsening despite furosemide use. And furosemide here, it's a diuretic medication, um, and the brand name in some countries might use Lasix. Um, Describing or reflecting for furosemide. Importance here guides an investigation of heart failure, renal dysfunction, kidney dysfunction, or venous insufficiency. And here is a summarized diagram on breaking down palpitations and syncope. Diagnostic standards in cardiology and pulmonology. Candidates are expected to demonstrate proficiency in documenting and interpreting key diagnostic tests as part of their exam. Echocardiograms in heart failure, HF, what to include: ejection fraction EF, valve function, hypertrophy, or chamber abnormalities. Example, EF, ejection fraction reduced to 25%, significant left ventricular dilation with moderate tricuspid regurgitation noted. Purpose: identifies heart failure severity and guides further management, such as device therapy like ICDs. PFT, pulmonary function test, metrics in pulmonary disease, essential parameters: FIV1 FVC, FIV1 over FVC ratio, and DILCO DLCO measures, not restrictive versus obstructive patterns. Example, FIV1 over FVC ratio reduced to 60%, consistent with obstructive disease, um, as it is less than 80% and less than 70%. If it's 70% and more, then it's fine, but less than 70% is obstructive disease. Bronchodilator trial resulted in 15% improvement in FIV1. Value differentiates between asthma, COPD, and interstitial lung diseases. Stress test or catheter lab outcomes. What to highlight: exercise thresholds, ischemia allocations, cath findings, for example, stenosis percentage. Example, stress test showed ischemia and anterior leads at 7 METs. Cath revealed 90% LAD LAD stenosis treated with DES placement. Use your guides revascularization, medical therapy intensification, or further monitoring post procedure. ECG or EKG interpretation accuracy, details needed, record rhythm abnormalities, ischemic slash infarct changes, and conduction delays. Example ECG, EKG shows atrial flutter with a ventricular rate of 120 peaked T waves present and precordial leads suggesting hyperkalemia, high potassium levels. Impact ensures immediate life-saving interventions and tailored therapies. Tracking biomarkers, key usage here, document troponin, BNP, or D-dimer results with clinical correlation. Example, BNP elevated to 680 pg over ml indicates acute CHF exacerbation likely secondary to dietary indiscretion. Relevance confirms diagnostic suspicions and offers measurable targets for therapy adjustments. Handling complex cases. The exam assesses candidates' ability to manage cases with overlapping or multifactorial symptoms, requiring nuanced care and documentation. Cardiopulmonary overlap. Focus here capture dynamics of both systems. Example, worsening CHF, congestive heart failure, exacerbated by COPD, chronic obstructive pulmonary disease flare. Example, FIV1 reduced to 45%, BNP at 900 pg over ml, CT reveals bronchial wall thickening indicative of a mixed presentation. Why necessary guides adjustment of diuretics, bronchodilators, and oxygen therapy. PE, pulmonary embolism, and acute dyspnea. Details here include Will's criteria. For example, tachycardia, Homan sign, and imaging confirmations. Example, CTA confirmed segmental emboli in left upper pulmonary artery and anticoagulation initiated immediately. Importance here addresses acute life-threatening conditions with a clear treatment flow charts. Restrictive lung disease cases. Approach combine pulmonary function tests, PFTs, CT scans, and symptom descriptors. Example, DLCO, DILCO reduced to 40%. Pulmonary function tests, PFTs shows 55%. FVC, biopsy pending for interstitial fibrosis confirmation. Clinical aim, objectively track progression or therapy response. Supporting multidisciplinary care, team coordination documentation is vital for managing complex cardiopulmonary cases. Cardiologist pulmonologist collaboration objective here document handoffs and shared findings. Example consults indicate HF heart failure worsening due to obstructive apnea. Pulmonology advised QAB CPAP titration. Relevance aligns care strategies across specialties. Chronic disease management focus longitudinal data tracking over visits with notes on stability or deterioration. Example, ejection fraction EF stabilized at 40% post AC inhibitor, angiotensin converting enzyme inhibitor, PFT pulmonary function test measurements, and change during follow-up. Goal measures success or identifies gaps in ongoing therapies. Pre-surgical/emergency context, documentation need, record pre-op clearances and procedure outcomes. Example, CABX ABG completed with no intra-op complications, extubated and stable at follow-up. Benefit reduces hospital stays with coordinated recovery support. Summary tables, table on essential components for symptom documentation. Symptom, key elements to document, example, importance, risks of omission. Symptoms, chest pain, dyspnea, cough, edema, palpitations. Table on key diagnostic standards in cardiology and pulmonology, test components and documentation, example, clinical relevance, risks of poor documentation. Tests, we have EKG or ECG, echocardiogram, pulmonary function tests, PFTs, troponin levels, imaging, CT, HRCT, X-rays. Table on approaching complex cardiopulmonary cases, condition, key documentation components, example, importance, risks of omission. Conditions we have cardiopulmonary overlap, silent ischemia, pulmonary embolism PE, interstitial lung disease, acute respiratory failure. Table on multidisciplinary care for cardiology and pulmonology cases, scenario, team members, and their role, example, importance, key benefits from proper collaboration. Scenarios we have acute MI, myocardial infarction, COPD, chronic obstructive pulmonary disease with congestive heart failure, CHF, post surgical recovery, chronic disease management, cancer with pulmonary symptoms. Table on compliance and final assessment preparation, focus area, documentation requirement, example, clinical impact, risks of non-compliance. Focus area ICD-10, accuracy, CPT application, patient consents, HIPAA compliance documentation for training. Next, we will revise what we have covered via this lecture through some MCQs or multiple choice questions. Question 1. Which of the following is a critical piece of information to document for a patient presenting with dyspnea or shortness of breath? A. The patient's last meal. B. The patient's exertion level and positional changes. C. The involvement of upper body fatigue. Or D. The time of day the symptoms worsen without further description. Now, the answer here would be B. The patient's exertion level and positional changes. As dyspnea, documentation must include whether it worsens with exertion or positional factors, for example, orthopnea, to differentiate between cardiac causes like congestive heart failure, CHF, or pulmonary conditions like COPD or asthma. Question 2. When assessing an ECG or EKG for exam documentation, which finding is most indicative of myocardial infarction, MI? Is it A. Prolonged PR interval without T wave changes? B. ST segment elevation in two contiguous leads? C. A flattened QRS complex in all leads? Or D. Ventricular tachycardia absent of R wave abnormalities? Definitely it's B. ST elevation. As ST segment elevation is contiguous leads is a hallmark of MI, indicating acute ischemia requiring immediate intervention. Question 3. Why is documenting the results of DLC or DILCO critical when interpreting pulmonary function tests, PFTs? A. To determine the need for bronchodilators without spirometry support. B. To assess gas exchange efficiency and the presence of bronchial lung disorders. C. To confirm restrictive patterns in isolation from imaging techniques. Or D. To replace the need for flow volume loop analysis entirely. Answer is B. To assess gas exchange efficiency and the presence of bronchial lung disorders, as DLCO measures the lung's ability to transfer gas and is essential in identifying conditions like pulmonary fibrosis or emphysema. Adding depth to the overall PFT report. Question 4. When handling a case of cardiopulmonary overlap syndrome, what must be a priority for the scribes documentation? A. Ignoring symptom contributions from one system if overlap is unclear. B. Clearly documenting both cardiac and pulmonary contributions to symptoms. C. Prioritizing PFT results over echocardiogram findings. Or D. Discarding any data without an immediate confirmed diagnosis. Answer is B. Clearly documenting both, as cardiopulmonary overlap often requires a comprehensive account of both symptoms to ensure providers develop accurate cross-disciplinary treatment strategies. Question 5. Which best describes the role of multidisciplinary care documentation for advanced cardiopulmonary cases? A. To streamline summaries by avoiding external team recommendations. B. To generalize therapy plans for broad application. C. To track detailed inputs from specialists aligning care strategies. Or D. To exclude post-discharge data meant for follow-up clinics. The answer would be C, as to track detailed inputs from specialists aligning care strategies, as proper documentation ensures cohesive collaboration across specialties, reducing miscommunication and optimizing treatment outcomes for complex cases. And here we come to the end of this lecture. Thank you very much and goodbye.